Good morning everyone. I am presenting subject seminar on the topic Morphology and Immunophenotype of Gestational Trophoblastic Tumors. Introduction. The trophoblast evolves during gestation, beginning as a relatively homogeneous extraembryonic proliferation, that is pre-villus trophoblast, followed by progressive organization and compartmentalization into various differentiation pathways. The latter process begins during embryogenesis and persists throughout life. Early on, trophoblast condenses around the mesenchyme to form villi, a process that defines the villus cytotrophoblast, which exhibits strong p63 and proliferative MIB1 immunostaining. This is how the trophoblastic lineages and their neoplasms occur. It starts with the pre-villus trophoblast, which are differentiated into villus cytotrophoblast, which are increased in complete mole and choriocarcinoma, trophoblastic column, which is increased in choriocarcinoma. Villus cytotrophoblast differentiates into syncytiotrophoblast, which is increased in partial mole, extravillus membranous and intraplacental vacuolated trophoblast, which are increased in epithelioid trophoblastic tumor. Trophoblastic column differentiates into superficial implantation site trophoblast, which is increased in placental site trophoblastic tumor. Gestational trophoblastic tumors represent a wide spectrum of neoplasms that originate from the extravillus trophoblast and have variable malignant potential. Most originate in the uterus and a few are encountered at other locations, both within the female genital tract and at other sites like lung. The World Health Organization classification of gestational trophoblastic disease organizes trophoblastic neoplasia into the following categories: malignant tumors, that is gestational choriocarcinoma, placental site trophoblastic tumor, molar pregnancies including hydatid form mole, which may be complete, partial, invasive, metastatic, and non-neoplastic conditions including exaggerated placental site known in the past as syncytial endometritis and placental site nodule or plaque. Choriocarcinoma. Choriocarcinoma is the most common malignant gestational trophoblastic neoplasm with differentiation towards the phenotype of villus trophoblast, including cytotrophoblast, intermediate trophoblast, and syncytiotrophoblast. Age: patients of reproductive age, mean age will be 30 years, although rare cases of gestational choriocarcinoma have been reported in postmenopausal patients after long latency. Gestational choriocarcinoma. Gestational choriocarcinoma may occur subsequently to a molar pregnancy in 50% of cases, an abortion in 25% cases, an ectopic pregnancy in 2.5%, or a normal gestation following 22.5%. Choriocarcinoma usually follows a recognized pregnancy, molar or other, by an interval of several months. However, prolonged intervals following gestation up to 14 years have been reported. Clinical presentation: abnormal uterine bleeding resulting from endometrial involvement by tumor. A variety of clinical presentations have been described, ranging from cervical or vaginal nodules to pulmonary, central nervous system, and liver metastasis with secondary cor pulmonale or intracerebral hemorrhage. Melena or hematuria secondary to involvement of gastrointestinal tract or renal tract have been reported, and metastasis to other even more unusual sites like extraocular muscle, skeletal muscle, and spleen have been described. This is the gross choriocarcinoma, presents as well circumscribed hemorrhagic nodule. Microscopically, the tumor consists of an admixture of syncytiotrophoblast, cytotrophoblast, and extravillus trophoblast with prominent hemorrhage, necrosis, and vascular invasion. The malignant trophoblast shows marked cytologic atypia and biphasic differentiation with small nests of cytotrophoblast with distinct cell boundaries and clear cytoplasm rimmed by multinucleated syncytial trophoblast. This is the choriocarcinoma showing extensive hemorrhage, and the tumor shows a biphasic pattern of cytotrophoblast and multinucleated syncytial trophoblast. Intraplacental choriocarcinoma. Most gestational choriocarcinomas present weeks to months postpartum. Grossly, a solitary, in fact up to several centimeters in size, or multiple, widely dispersed 5 mm small white nodules. Microscopically, atypical, biphasic, solid trophoblastic proliferation is located in the maternal intervillous space multifocally adhering to villus stroma. Hyperchromatic, mitotically active, primitive appearing cytotrophoblast is admixed with syncytial trophoblast. This is the intraplacental choriocarcinoma. A highly atypical proliferation of biphasic trophoblast is present within the maternal intervillous space adherent to villus stroma. Immunophenotyping. Trophoblastic markers include HPL, HCG, MEL-CAM, that is CD146, P63, MUC4, HLA-G, cytokeratin 18 and inhibin A. As choriocarcinoma contains a variable admixture of cytotrophoblast, intermediate and syncytial trophoblast, all of these markers are positive to a variable extent in this tumor. GATA3 is a recent addition with around 80% of choriocarcinoma showing nuclear positivity of variable intensity. This is the World Health Organization Prognostic Index score for gestational trophoblastic disease. Prognostic factors and scoring. Age, it's given grade 0 if it's less than 39. If it's more than 39, a score will be 1. Antecedent pregnancy. Hydatid from mole, score will be 0. Abortion 1. Term pregnancy will be 2. Interval, beta HCG less than 103, 103 to 4, and more than 105 will be grade 4. Largest tumor including uterine tumor more than 5 centimeters will be grade 2. Site of metastasis: spleen, kidney, GI, liver and brain. Number of metastasis identified more than 8 will be high grade, that is score 4. Prior chemotherapy, if it's 2 or more drugs, then its score will be 4. The total score for a patient is obtained by adding the individual scores for each prognostic factor. Low risk 0 to 4, intermediate risk 5 to 7, and high risk will be 8. Interval is time between end of antecedent pregnancy and start of chemotherapy. Metastasis: if untreated, choriocarcinoma metastasizes in more than 50% of cases, frequently to the vagina, lung, liver, brain and kidney. Treatment: in most cases the uterus can be retained. Hysterectomy is performed in those patients in whom preservation of the reproductive function is not desired and who are unresponsive to chemotherapy alone. Surgery also remains useful in controlling life-threatening hemorrhage from metastatic lesions. Chemotherapy is the mainstay of treatment for choriocarcinoma, with overall cure rates of more than 90%, as these are highly chemosensitive tumors. Now coming to placental site trophoblastic tumor. A placental site trophoblastic tumor is a rare type of gestational trophoblastic neoplasia that forms where the placenta attaches to the uterus. The tumor forms from trophoblast cells and spreads into the muscle of the uterus and into the blood vessels. It occurs following normal pregnancy and it is recognized years after an antecedent gestation. Clinical presentation: irregular bleeding and a low serum positive serum beta HCG level, amenorrhea, infertility, and nephrotic syndrome. Grossly, placental site trophoblastic tumors are tan to red solid nodules with variable necrosis and hemorrhage, and typically involve the endometrium and myometrium. This is placental site trophoblastic tumor. A solid tan mass involves the endomyometrium. Microscopy: it is characterized by a diffuse and infiltrative growth of monomorphic intermediate trophoblast arranged in sheets and cords. These are typically seen to separate myometrial fibers, that is splitting, and replace uterine blood vessels walls with extensive fibrinoid deposition reminiscent of the normal implantation site. This typical pattern of vascular invasion with overall maintenance of vascular architecture is characteristic of placental site trophoblastic tumor. Here we can see the scattered atypical and multinucleated cells. Neoplastic extravillous cytotrophoblastic cells are seen infiltrating the myometrium. Here we can see infiltrating the myometrium. They are splitting the myometrial fibers with no evidence of hemorrhage or necrosis. Genetics: in general, compared to choriocarcinoma, most placental site trophoblastic tumors are diploid. There is a confirmed and marked female predominance of these gestational trophoblastic tumors, which remains unexplained, but genetic studies have otherwise demonstrated no consistent chromosomal loss or gain. Molecular genotyping is used to determine causative pregnancy in these tumors as it has major prognostic implications. Coming to immunophenotyping, cytokeratins AE103, CAM 5.2 and CK18, CD10, HLA-G and GATA3 in keeping with trophoblastic lineage. Most cells express HPL, MUC4, MEL-CAM, while occasional may be positive for PLAP and P63. HCG and inhibin expression is limited to multinucleated cells. Proliferation index is usually low as compared to choriocarcinoma. Prognostic and predictive factors: most patients are cured by simple hysterectomy. However, 25 to 30% of patients may develop recurrent disease and about a half of those may die of the tumor. Histological parameters that correlate with prognosis include tumor cells with clear cytoplasm, depth of invasion, tumor size, necrosis, and high mitotic count, that is more than 5 per 10 high power field. Next is epithelioid trophoblastic tumor. This more recently described and rarest form of gestational trophoblastic tumor was initially termed atypical choriocarcinoma with subsequent recognition as a distinct entity. A trophoblastic tumor consisting of neoplastic chorionic type intermediate trophoblast. Epithelioid trophoblastic tumor may be located with equal frequency in the lower uterine segment or cervix in 50% of cases as in the uterine corpus. It occurs most commonly in the age group between 15 to 48 years. Clinical features: vaginal bleeding or menometrorrhagia are the most common symptoms. Antecedent gestations include term pregnancy in 67% cases, spontaneous abortion in 16%, and hydatid-form mole in 16% of cases. Interval between previous gestation and diagnosis of an epithelioid trophoblastic tumor may be quite long. Average is 6.2 years and is slightly longer than that seen in placental site trophoblastic tumor. The most common presenting complaint will be abnormal vaginal bleeding, amenorrhea, or rarely patients may present with metastasis. As with placental site trophoblastic tumor, serum HCG is almost always elevated at the time of diagnosis, but levels are very low, less than 2500 micro international units per liter in most cases. Grossly, it presents as solid or cystic, white or tan nodules with frequent areas of necrosis and hemorrhage. Tumor size may range from 5 to 50 mm with macroscopic involvement of deep myometrium and adjacent structures. Microscopy: monotonous population of mononucleated intermediate trophoblast arranged in nest, cords and islands. The tumor cells have eosinophilic or clear cytoplasm, well-defined cell membranes, and round uniform nuclei, and are smaller and show less nuclear pleomorphism than placental-side trophoblastic tumor cells. Mitotic count ranges from 0 to 9 per 10 high-power fields, but mitosis up to 48 per 10 high-power fields may be present. This is how the epithelioid trophoblastic tumor looks like. There will be monotonous population of mononuclear cells will be seen. Immunophenotyping: cytokeratin CK18, AE13, CAM 5.10, 5.2, CD10, HLA-G and GATA3. EMA, cyclin E, P63, inhibin and PLAP are usually diffusely expressed, whereas MEL, CAM, HCG, HPL expression is weak and focal. P63 is reliably positive in epithelioid trophoblastic tumors. Histiogenesis: it arises from trophoblast with differentiation towards chorionic type intermediate trophoblast. Prognosis and predictive factors: metastasis occurs in 25% of cases and 10% of patients dying of disease. The survival is nearly 100% for non-metastatic cases but decreases to 50 to 60% in patients with metastasis. Among the histological features, only high mitotic count, that is more than 6 per 10 high-power field, was found to be an unfavorable factor. These are the diagnostic features of the three neoplastic gestational trophoblastic tumors. Age in choriocarcinoma will be reproductive age. In PSTT, 20 to 63 years. And epithelioid trophoblastic tumors will be 15 to 48 years. Antecedent pregnancy: it occurs following term pregnancy, complete hydatid-form mole. PSTT also occurs in term pregnancy and epithelioid also occurs in term pregnancy. Interval time from index gestation: a few months to 14 years. In PSTT, 2 weeks to 17 years and ETT 1 to 25 years. Clinical presentation most commonly will be vaginal bleeding, persistent gestational trophoblastic disease, missed abortion and amenorrhea in PSTT, and vaginal bleeding in ETT. Pre-treatment HCG level: more than 10 into 10 raised to 3, less than 1 into 10 raised to 3 and less than 3 into 10 raised to 3. Gross appearance: choriocarcinoma will be circumscribed or invasive hemorrhagic mass. PSTT expansile to infiltrative solid mass and ETT will be expansile solid mass. Tumor location: it will be choriocarcinoma in uterine corpus, PSTT in uterine corpus. ETT occurs in cervix, lower uterine segment or corpus. Tumor borders in choriocarcinoma will be infiltrative, in PSTT also infiltrative and ETT pushing. Tumor growth pattern: trimorphic pattern consisting of all three types of trophoblast, extensive hemorrhage and necrosis. And PSTT, large masses of tumor cells replacing vascular wall, tumor cells split, myometrial smooth muscle fibers at tumor periphery. And in ETT, sheets, nests and cords, geographic necrosis, deposition of hyaline-like material and colonizing mucosal surface epithelium. Tumor cells: villus intermediate trophoblast, cytotrophoblast and syncytiotrophoblast. And in PSTT, implantation site type intermediate trophoblast and in ETT, chorionic type intermediate trophoblast. Cytological atypia will be marked in choriocarcinoma, moderate to marked in PSTT, and mild to moderate in ETT. Stroma. In choriocarcinoma, no intrinsic tumor stroma or vasculature, Ki67 labeling index more than 90%. Intimately infiltrates myometrial muscle fibers in PSTT and presence of nearby decidualized stromal cells in ETT. IHC diffusely positive for HCG, HPL, HSD3B1 in syncytial trophoblast, and diffuse positive for HPL, MELCAM, scattered multinuclear cell positive for HCG, Ki67 labeling index of 5 to 10% in PSTT. Diffuse positivity for P63, rare individual cells positive for HPL and MELCAM, Ki67 labeling index of more than 10% in ETT. Next, coming to molar pregnancies. Hydatid form mole, an abnormal placenta with variable degrees of trophoblastic hyperplasia and villus hydropes. The presence of excessive paternal genome is the fundamental genetic etiology. Coming to epidemiology, the prevalence of gestational trophoblastic disease varies markedly by country, with the highest incidence of hydatid form mole in Southeastern Asia, 3.8 to 13 per 1000 pregnancies, and lowest incidence in US and Europe, 0.5 to 1.8 per 1000 pregnancies. Risk factors include maternal age less than 15 years and more than 40 years, previous hydatid form mole, Asian ethnicity and genetics. And possible risk factors which are of less significance are diet and socioeconomic status, gravidity, oral contraceptive use, parity, smoking, herbicides, paternal age, and blood type. Complete mole. It's caused by abnormal gametogenesis and fertilization. The nuclei of the trophoblastic cells in this disease contain only paternal chromosomes and are therefore androgenetic in origin, whereas all cytoplasmic DNA is maternally derived. The chromosomal number is normal. 85% of cases are 46XX and 15% are 46XY. Age: older than 30 years of age and more likely to have diets deficient in vitamin A precursors. Incidence 1 in 2000 deliveries. Histiogenesis: complete hydatid form moles have proliferating cells recapitulating chorionic villus trophoblast. Clinical presentation: complete moles typically present in the late first trimester or early second trimester with vaginal bleeding, absent fetal heartbeat, inappropriately enlarged uterus, markedly elevated beta human chorionic gonadotrophin levels, and characteristic snowstorm ultrasonography finding. Grossly, specimens of complete hydatid form mole are usually bulky with numerous transparent and grape-like swollen villi measuring up to 2 cm in diameter. Microscopy: the two constant features of a complete mole are hyperplasia and vesicular swelling. Some of the villi are surrounded by an attenuated layer of degenerating trophoblast. In others, the trophoblast forms large hyperplastic sheets of cells. The distended core of the villus is traversed by widely separated, broken strands of fibrillar material, that is cistern formation. Vessels seem absent or very scant. Stroma shows stromal mucin and stromal nuclear debris. Complete mole: this is the complete mole showing large villi. These are the large villi with stromal edema and marked trophoblastic proliferation. Immunophenotyping: HCG is widely distributed and PLAP is patchily distributed in the molar syncytial trophoblast regardless of gestational age. HPL tends to increase with increased gestational age. Both alpha and beta units of inhibin are evident in the molar syncytial trophoblast. P57 KIP2 protein, a cell cycle inhibitor and tumor suppressor, is encoded It is well expressed in cytotrophoblast and villus mesenchyme of normal pregnancy, spontaneous abortion, and partial moles, but absent or markedly decreased in complete moles. Treatment. The initial therapy of complete mole consists of evacuation of the uterus by curettage. This is followed by sequential quantitative determination of beta subunit of HCG. The standard recommendation has been to measure the serum levels of HCG at 10, 20, 30, 45 and 60th days after termination of the molar gestation. In approximately 80% of cases, normal levels will be reached by day 60. If there is rising titer between 45 and 60th day or the level is still elevated by day 60, chemotherapy is administered. This is necessary in approximately 20% of cases. Prognostic and predictive factors. The prevalence of persistent gestational trophoblastic disease is 15 to 29%, and 22 to 3% of the patients develop choriocarcinoma. The risk of persistent gestational trophoblastic disease may be higher for heterozygous complete hydatid form mole than for homozygous ones. The risk of subsequent complete hydatid form mole is 1 to 1.8% after one prior and 10 to 18% after two consecutive hydatid form moles. Partial mole. 15 to 30% of all moles are of partial type. In contrast to complete mole, the condition is often associated with the presence of an embryo, although this is usually abnormal, that is blighted ovum. Most partial moles are triploid, 69 XXX or 69 XXY, and a few show trisomy 16. The extra material is of paternal derivation, so-called diandric triploidy. Clinical features. Patients presents with vaginal bleeding or missed or incomplete abortion in the late first or early second trimester, normal or mildly elevated serum HCG and a focally cystic placenta on ultrasound. Fetus may be detectable. This is the gross. The volume of placental tissue is relatively normal and the gross vesicular villi are admixed with normal appearing tissue. Microscopy. Focal edema leading to central cisternal formation and stromal inclusions of trophoblast. Many of the villi have an irregular scalloped outline and contain vessels with fetal, that is nucleated red blood cells. Fibrosis of the villus stroma is common. Partial mole showing scalloping of villi and isolated trophoblastic cells embedded in the stroma. Histogenesis. Partial hydatid form mole has proliferating cytotrophoblast and syncytiotrophoblast, recapitulating chorionic villus trophoblast. Prognostic and predictive factors. Persistent gestational trophoblastic disease. Mostly invasive hydatid form mole occurs in approximately 0.5 to 5% of partial hydatid form mole. The risk of developing choriocarcinoma is less than 0.5%. These are the diagnostic features of complete hydatid form mole, very early complete hydatid form mole and partial hydatid form mole. We can see clinical presentation in the second trimester, average is 16 weeks, excessive uterine size, hyperemesis, toxemia, preeclampsia or hyperthyroidism in very early missed abortion, 6.5 to 12 weeks of gestation and partial in presence with vaginal bleeding, missed or incomplete abortion in the late early or early second trimester. Pre-treatment HCG levels. It will be more than 100 into 10 raised to 3 in more than 43% of cases, and very early it will be normal, and in partial also it can be normal or elevated. On ultrasonography, we can see snowstorm pattern without fetus formation in complete and in partial focal cystic change with fetus formation. Macroscopy. Bulky specimen with hydropic change involving all villi, absence of gestational sac and fetal development. In very early, frequently no gross abnormality will be detected, and in partial, hydropic change involving some villi, gestational sac and fetal tissue may be present. Chorionic villi in complete will be diffuse enlargement, round to oval shapes, very early normal size, polypoid or cauliflower shapes, and in partial, mild with syncytio-trophoblast knuckles. Trophoblastic hyperplasia, it will be marked and it will be mild in case of very early and it will be mild in partial. Cytological atypia, marked in complete, mild to moderate in very early and limited to mild in partial. Villus-Troma, marked edema with frequent cistern formation and trophoblastic inclusions and absence of vasculature and nucleated RBCs. Cellular and myxoid with prominent karyorrhexis. Fetal capillaries may be present. Occasional cistern formation, round to oval trophoblastic pseudo-inclusions, presence of vasculature and nucleated RBCs. P57 immunostain, absence of nuclear staining in cytotrophoblast and villus stromal cells in complete. In very early, absence of nuclear staining in cytotrophoblast and villus stromal cells, and in partial, presence of nuclear staining in cytotrophoblast and villus stromal cells. DNA genotyping, diploid diandric paternal only genome in complete, diploid diandric paternal only in very early, and triploid diandric monogynic in partial. Invasive mole. The term invasive mole, chorioadenoma destruens, refers to a hydatid form mole, nearly always of the complete type, but occasionally of the partial type, in which villi penetrate deeply the myometrium or its blood vessels. It occurs in 16% of all complete moles, is an exaggerated expression of the capacity of normal trophoblast for invasion, a necessary property for implantation. Coming to clinical features, vaginal bleeding with persistent elevation of serum HCG after primary evacuation of a hydatid form mole is characteristic. Histogenesis, both complete and partial hydatid form moles may develop into invasive hydatid form mole. This is the gross appearance. A hemorrhagic mass has permeated half of the thickness of the myometrial wall. Microscopy, hydropic villi with atypical hyperplastic trophoblast are found within the myometrium or blood vessels. We can see hydropic villi covered by proliferating trophoblast are seen permeating the myometrium in invasive mole. Prognosis and predictive factors. Chemotherapy is highly effective with a cure rate over 80% depending on the extent of the disease. Now coming to non-neoplastic lesions. Exaggerated placental site reaction. Excessive but otherwise normal infiltration of the implantation site by intermediate trophoblast. Clinical features. The lesion is associated with normal gestation or hydatid form mole and has no specific clinical symptoms. Histogenesis. Exaggerated placental site reaction has the morphological and immunohistochemical features of intermediate trophoblast at the implantation site. This is the microscopy. The lesion is microscopic in size and lacks mitotic activity, contains a hyaline material between the trophoblastic cells and is admixed with decidua and villi. We can see trophoblastic cells infiltrating the myometrium in a tumor-like fashion in exaggerated placental site reaction. Placental site nodules and plaques. Single or multiple, mostly well circumscribed, variably cellular, round or flat lesions, nodules and plaques respectively, that tend to be extensively hyalinized. Most cells have abundant amphiphilic or acidophilic cytoplasm, irregularly shaped nuclei, and very scanty mitotic activity, but others have a glycogen-rich clear cytoplasm. Mallory bodies may be seen. Clinical features. Placental side nodules are reported in the reproductive age group and are derived from intermediate trophoblast of chorion leaf type. It is often an incidental finding in endometrial curettage performed for bleeding abnormalities, abnormal cervical smear, or other indications. A significant association is seen with a history of a tubal ligation, and many have a history of therapeutic abortion or caesarean section. Grossly, the lesion is nodular, ranging in size from 4 to 10 mm. Histogenesis. PSN has the morphological and immunohistochemical features of chorionic type intermediate trophoblast. This is the low and medium power view of placental side nodule. The appearance is vaguely chondroid and can be easily misinterpreted. Immunophenotype. This lesion, like other trophoblastic lesions, is positive for anti-cytokeratin antibodies and are invariably positive for alpha inhibin, EMA, and GATA3. Most lesional cells express PLAP and P63, while a small number are positive for HPL and MELCAM, that is CD146. Prognosis and treatment. Although typically placental side nodules do not require follow-up, limited data regarding APSN have shown an association with malignant GTT in 15% cases. These developed either concurrently or within 16 months of the APSN diagnosis. Furthermore, examples of PSTT or ATT in hysterectomy specimens in which morphological areas of both PSN and PSTT-ETT are present have also been reported. Abnormal, that is non-molar villus lesions. Various non-molar villus lesions with histological features simulating a partial hydrated form mole. Clinical features are missed abortion or incomplete abortion. Macroscopy, they vary from normal gross findings to discernible vesicle formation. Entities include hydropic abortions, chromosomal trisomy syndromes, digenic triploid conceptions, and placental mesenchymal dysplasia, Beckwith-Widman syndrome. Microscopy. Chorionic villi often display some degree of irregularity in size and shape, with focal, mild trophoblastic hyperplasia and occasional trophoblastic inclusions, thus having a partial spectrum of the histological alterations seen in a partial hydrated form mole. Histogenesis. They have diverse origins related to the specific diagnosis causing the abnormal villus morphology. Genetic profile. Diverse chromosomal or genetic alterations may be found. Prognosis and predictive factors. These are non-molar entities and thus have the same low risk of persistent GTDs as any other morphologically unremarkable non-molar conception. Mixed gestational trophoblastic tumors. Although gestational trophoblastic tumors are generally described as clinically and pathologically distinct entities, it has become increasingly recognized that tumors with morphological and immunophenotype of choriocarcinoma and PSTT or ETT can coexist. These are my references. Thank you.